Hello, everyone, and thank you for joining us today. I'd like to welcome all of you, both those online and here in person, to today's presentation on focused ultrasound for the treatment of disorders of the central nervous system. This is a perfect topic for discussion, considering after last week's webinar on Alzheimer's disease, where we learned more about the challenges for treating Alzheimer's and the potential role focused ultrasound could play. Today we hear from Dr. Elisa Konofagou, who has been a leader in the field of using focused ultrasound to open the blood-brain barrier to enable treatment of Alzheimer's as well as Parkinson's disease and other neurological disorders. A quick note for those on the webinar, if you'd like to ask a question of Dr. Konofagou, please submit it via the chat function. We'll collect these questions until the Q&A period at the end of the presentation. And now I'd like to introduce Dr. Elisa Konofagou. She's a professor of biomedical engineering and radiology at Columbia University, where her lab works on developing novel ultrasound-based techniques for both imaging and therapeutic applications. As I alluded to before, she is one of the world's experts in using focused ultrasound to open the blood-brain barrier to enable drug delivery to the brain for a wide range of clinical uses. We look forward to hearing about this work today. Elisa?
Thank you very much, Jessica, and it's a pleasure to be here in person in the foundation, but also on the webinar, on the web. And it gives me a pleasure and opportunity to actually share with you what we have been doing on the brain over the past few years, which is about 11 years now. The diseases that we're actually very interested in over the past few years, as I said, are actually neurodegenerative diseases such as Alzheimer's and Parkinson's. As you can see from this specific illustration, they actually are affecting very deep regions in the brain, which makes it very suitable for focused ultrasound. You have Alzheimer's disease that typically in its earlier onset hits the hippocampus and the neuronal cortex, and Parkinson's disease that affects the striatum and the substantia nigra. At the same time, as we speak, there is a big rise of neurodegenerative diseases as a prevalence. This is just something that came out a few years back for rate of increase in certain diseases. The top killers in the country per 100,000 population, you see Parkinson's disease and especially Alzheimer's disease since the early 80s on a very large rise, mainly, of course, because of earlier diagnosis, but of course also for the population getting, as an average, older. So you have in both Parkinson's and Alzheimer's disease the prevalence that's there, so about 5 million in the U.S. In 2014, and a few of them are actually under the age of 65, so it also affects younger people relatively. And the several deaths, so it's one of the most prevalent diseases that leads to death. And of course, Parkinson's, 1 million people affected in the U.S., and a lot more people actually than Alzheimer's are affected under the age of 50. It also is a huge cost for healthcare. In 2014 alone, Alzheimer's cost 214 billion, and a lot of that actually went to Medicare and Medicaid, and it's projected to go to higher than $1 trillion by 2050, given that the population is on the average older. And the same thing for Parkinson's, 25 billion per year in the U.S. For treatment, and the rest that comes with healthcare. So it's a big issue in the U.S., of course, and worldwide as well. And something that we've been actually looking at is what comes between treatment of these diseases when actually the drugs are available. It's actually the blood-brain barrier. And you see a cross-section here of the smallest blood vessels in the brain that are called the capillaries. And you have the blood that actually flows in what is shown here as white, which is basically the lumen. And we're trying to reach, obviously, the neurons that are in the parenchyma here. This is a scanning electron microscopy image. And it looks like, obviously, this is on the order of 4 to 10 microns in diameter, and these are a few microns between the lumen and the neuron that needs to be treated. But it is a huge distance between the two, given that there's a lot of impediments to reach that neuron from getting the drug into the actual vessels in the system and trying to treat the neurons in the parenchyma. The barrier itself, which is basically made up of tight junctions, which are protein strands that are actually linking the endothelial cells that line all these blood cells together, as well as some transport systems and enzymes that can be found. All these make up what's called the neurovascular unit. That's the main impediment. For the healthy brain, it works perfectly. It actually eliminates everything above 400 Daltons, all the molecules that are flowing in the blood. Anything above 400 will not cross the blood-brain barrier, but it's a big, as I said, obstacle for treatment of these diseases. So I don't know what happened to this. I'm sorry about this. There was supposed to be an illustration here. So the blood-brain barrier is a very permeability barrier in all the cerebral microvessels. It accounts for 99% of molecules that are greater than 400 Daltons cannot penetrate it. And unfortunately, that translates to only 5% of the drugs that are more than 7,000 that have been developed for the central nervous system that cannot cross it. So it has been defined as a rate-limiting factor in brain drug delivery. So so let me see. This is an illustration here. No. So I'll go back. Sorry about that. So for focused ultrasound, this doesn't need, for those who are here and who are in the field, this is just a refreshing slide of how it works. We basically have a transducer that is curved and has a geometric focus, which is defined by the geometry and also the center of frequency or wavelength of the transducer that is being excited. And the curvature, very similar to an optical lens, leads to a specific focus that can be on the order of millimeters. And that can be adjusted, obviously, with the F number and diameter, so focal depth and diameter of the actual transducer. So the way we actually are using it in vivo, the first part is going to be on mice, and the second part is going to be on monkeys. So for mice, which we actually started with and we're still continuing in my lab, we basically do it very non-invasively. The first thing we do on the mouse is actually shave the fur, and that's the only thing we do. Everything else is intact, and then we target with a specific metallic grid that aligns with the sutures of the brain. Then we have microbubbles that are injected IV, intravenously, and then we apply focused ultrasound after injection and try to target, as I mentioned earlier, in the hippocampus first, and then also, as I show later on, caudate putamen and substantia nigra that are affecting Parkinson's disease. So the blood-brain barrier opens within seconds, and then we inject molecules after the fact, which can be either contrast agents that we see on the MRI, where the actual opening has occurred. Those contrast agents do not cross the blood-brain barrier. They're slightly larger than the blood-brain barrier. Or we can also inject actual drugs that also don't cross the blood-brain barrier but actually treat the disease. And the advantage here is that it's non-invasive opening. It is actually opening in specific regions of the brain, leaving the rest of the brain intact. So it is selective. It closes back, so it's transient. You could have just a single application of ultrasound over a minute, as we actually do usually in mice, and affect the entire structure. And we don't necessarily require MRI guidance in real time. This is a movie that I will play in a second. It shows you, it's an illustration, of course. We wish we could do this actually in vivo. Unfortunately, we can't. This is the blood vessel that I talked about, the capillary. This is a transverse section of the capillary. Red blood cells are flowing together with the microbubbles that we inject IV. And the drug is actually purple here. This is the one we want to deliver across the blood-brain barrier. So let me stop it for a second there and show you the movie. So you have the bubbles, microbubbles here that are flowing together with the drug, and the neuron is right here that we're trying to reach. And you're going to see the ultrasound itself being applied, and the microbubbles are actually starting to cavitate, and the drug goes through the opening of the tight junctions here. Okay, sorry about that. So this is the idea, and we are trying to obviously induce cavitation effects, as I mentioned. We can be in the what's called the stable cavitation regime, which is actually at 0.3 megapascals, which we find to be around the threshold at 1.5 megahertz for opening the barrier. And this is just an ultrasound image that shows you how these microbubbles are used as contrast. So this is actually what we call a channel in a phantom, where we have injected microbubbles, and you can see that where the microbubbles are, you have enhancement of the image, and everything else is dark. And then you can also look at how the microbubble signal changes over time as we switch on the ultrasound here. And then the frequency response, which shows you, sorry about that, the harmonics. So you can be actually in the stable cavitation regime, which means that you only have the bubble oscillating non-linearly or linearly, and you see these harmonics here that appear on the spectrum and also ultraharmonics. But you also can burst the bubble. So this is called inertial cavitation, and you see right in this region where we focus the ultrasound, you have the bubbles that are actually disappearing, and this is actually after bursting. And you see this large amplitude on the time response of the bubble, so you can hear the actual bubble pop. This is actually with cavitation detection. And instead of just having the harmonic peaks here, so this is actually regular peaks here of having stable cavitation, you also have the entire spectrum now rise from interrogating all these different frequencies of the microbubbles. So both of these things could happen. Obviously, the stable cavitation is how we want to open the barrier to make it as safe as possible. And the good news is that we can actually use the stable cavitation only to have this still work. The barrier does open, and we can get the drugs through. So for the gadolinium part, this is MRI images at opening. The first three, the T1 weighted image shows you, in this case, we have targeted the coded putamen, the substantia nigra. And what I'm showing you in the middle is actually the entire three-dimensional view of the brain, and where we actually have opened the two regions, and everything else in the brain except for the ventricles and the large vessels, which actually have the gadolinium, highlight those just by regular MRI. Everything else is dark. And then the T2 weighted shows you potential occurrence of edema, and you can see the region where we opened here in the coded putamen and the substantia nigra are actually very similar in amplitude to the contralateral side where we didn't open. So that tells us that the opening was safe. And something else that we have been publishing on for a while now is the microbubble side. So typically, us included, we were actually using the microbubbles. As I said, they were commercial agents used for contrast agents in ultrasound imaging. So we would actually buy those and use them, use the vial as is. And with collaboration with Mark Borden, when he used to be at Columbia, he devised a method where we can actually sort the bubbles and separate them through suffusing from separate the 1 to 2 microns to, from 4 to 5 microns, and later on I'll show you also the 6 to 8 microns. And what happened when we actually injected those into the mice and everything else was kept equal, we actually saw a big difference in the opening volume. So when you have the 1 to 2 microns at the same ultrasound parameters, you get a very small opening of the barrier, barely detectable. And then the same ultrasound parameters with just slightly different bubbles, and you can see the difference from the two images here. We have the entire hippocampus lighting up. So what this gave us is actually control over the volume of the barrier, which is actually very important outside of the ultrasound parameters, but actually having the microbubbles dictate the where we're actually opening and also how big of the volume it is. And the reason why this is happening, we believe it has to do with the fact that we are matching the size of the capillaries. As I mentioned, on the order of 4 to 10 microns. So as your bubble size is increasing, you have higher probability of the bubble as it expands to engage the blood vessel earlier. So more of these bubbles are actually going to induce openings than the smaller bubbles. And a visual of that with both ultrasound parameters and microbubbles is shown here. So we have 3 different pressures, which is pretty much where we have found the focused ultrasound to be safe with 4 bladder and berry openings ranging from 0.3 to 0.6 megapascals, and then changing the diameter from 1 to 2 microns to 6 to 8 microns. So you go from no opening at all, which is actually what you see here on the left for each pair is actually the 3-dimensional MRI. And on the right is the permeability image that we can actually now generate, which shows us how permeable brain has become as a result of the opening. So you get 0 permeability of the brain in the region where you have sonic aid, and a very, very small opening, if any, here in the hippocampus. And as you're increasing the pressure and increasing the size of the bubbles, you get the much bigger opening volume that's highlighted here by the gadolinium, and also a permeability increase that is of several orders of magnitude. Obviously, when you're at 0 and you increase it up here, it's the several orders of magnitude increase of permeability, very nicely localized in the brain. So we have control over that. Obviously, it can be smaller sizes and lower permeability if you need to, compared to how safe or how potent the drug needs to be. So that's all with gadolinium, and of course, gadolinium, as I said, is slightly larger than the threshold, but it has almost, other than that, it just highlights where the opening volume occurs, and it's a great way of actually following up on whether the technique worked or not. But the drugs that are out there, available, the 7,000 drugs that I mentioned earlier, they're orders of magnitude higher than the gadolinium. So gadolinium molecular weight is on the order of 600 Daltons. We have some inhibitors that are on the order of thousands of Daltons. Some of the antibodies that have been shown promising in the treatment of Alzheimer's are on the order of 100,000 of kilodaltons. And of course, some of the viral vectors that I showed you later are on the order of megadaltons. So we needed to actually see whether the opening was relevant for drugs. It was definitely relevant for gadolinium, but that was not sufficient. So in this case, we have now fluorescence imaging, just because MRI shows you very nicely, as I said, gadolinium, but doesn't show you larger molecules. This is a coronal slide of the hippocampus, and we have injected here fluorescent dextran, which are sugar molecules on the order of 70 kilodaltons, which is 2 orders of magnitude higher than the gadolinium. And we have actually here perfused the entire hippocampus, which is actually great news for us. So you can get the entire structure very nicely localized with the large molecules as well. So it does translate to larger molecules. And now if we start zooming into those regions that uptook the drug, something that we were trying to see where the opening is occurring, you can see some of the bigger arteries, which are also having barriers. Now people know that it's not just the capillaries that have the blood-brain barrier, it's actually also on the larger vessels. They tend to actually stick on the smooth muscle cells, and the smooth muscle cells are actually the cells that make sure that the arteries are contracting properly at every arterial pulse. So it makes sense that they will respond to the mechanical impulse, such as the ultrasound beam. So, just what we have shown in Alzheimer's a while back in amyloid precursor protein mice, the double transgenics. That's one of the lines that our collaborator Karen Duff is actually having at Columbia. So we have the same timeline of the actual opening over the course of 90 minutes. You can see the whole hippocampus in now this double transgenic mice. So, and also the closing, very similar to what we see in wild-type mice, and the brain. Oops, sorry, what's going on? Did I press the wrong button? Where your mouth wire is. Okay. Oh, sorry. Okay. And we have the pathology that's very different. This is the wild type that I showed you until now on the right, and these are the amyloid plaques that are actually in the hippocampus on the left. So we can open in the barrier in the presence of this amyloid. Similar to what I showed you in the previous slide, the closing is something that we have also are looking at. So how long is the duration of the opening? This is just an illustration of the hippocampus, obviously in pathology, how we can actually assess the structure and the shape of the hippocampus when we open it with gadolinium. And the next day, we inject exactly the same amount of gadolinium, and nothing goes into the brain. So we actually can assess the closing that way. And I'll show you some more of the closing, blood barrier closing illustrations in both mice and monkeys later. But here is actually something that we published 5 years ago, approximately, was for the entire, trying to identify the pressure range where this is safe. And what we did is actually, where the gadolinium is actually infused in the hippocampus, we will actually get the histology right on that plane. The left hippocampus will be the sonicated region, and the right hippocampus will be the contralateral. And we saw no damage at this pressure. And as we increase the pressure, we will see red blood cells inside the vessel, so no extravasation at 0.45 megapascals. And we're always looking at the region that had the highest enhancement of the MRI. So this will be the highest uptake of gadolinium, and this is how we were orienting the histology. So this will be the higher likelihood of damage. So, and then finally, at 0.6 megapascals, we would see some types of red blood cell extravasations. And those were actually mice that were sacrificed 4 hours after the experiment. And what we found out after this paper was that 7 days later, this is actually reversible damage. We will not see these red blood cell extravasations anymore. So we also have been doing safety experiments on these mice. So this is something that was funded by the Kinetics Foundation, and we're trying to see how whether any behavioral changes in the mouse, other than obviously the histology, was changing. And in a nutshell, this was actually done with some sonicated mice every 2 weeks, every month, and we were getting them over the course of 6 months, several groups. I think we had up to 10 groups, and one was positive control, so we were sonicating at 1.45 megapascals, and this is the only group of positive control where we actually saw differences in the behavior of these mice and the movement changes. So going back to the closing timeline and reversibility, we have shown that this is actually day 0 of 0.3 megapascals with larger bubbles, and you see the opening in red here. And day 1, some of the actual closing has started, especially at the lower pressures that are on the tails of the Gaussian shape of the actual focal spot, and then it takes a couple of days to get more of these regions to close, and finally day 3, all of them are closed at those specific parameters. Actually, we've done more of this work, and if you have smaller, shorter pulse lengths or smaller bubbles, you can actually decrease the timeline down to 3 hours. And this is what I'm showing you here. So we have separated, this is blood-brain barrier opening volume at the first day of opening over the course of days. So looking at the volume on an MRI after 5 days out of the opening for 1 to 2 micron bubbles, 4 to 5, and 6 to 8. And we've shown that as you increase the pressure, it takes much longer for the blood-brain barrier opening to recover, as opposed to lower pressures where it can take on the order within a day. And going back to the size, to the molecular sizes, after showing you this safety studies that we have done so far, we wanted to see where it's actually very relevant for drug delivery. As I mentioned, this can be from 3 kilodaltons to actually upwards of 2 megadaltons. These are the fluorescent dextran ranges that we could actually find and use. So this is some of the work that Hong Chen did in my lab, where we're actually looking at different pressures. So the hypothesis here was that the higher the pressure, the larger the molecule that will have to go through, and actually it was proven right. At 0.3, you can get small molecules to go through, and especially at 0.5, and this will be the stable cavitation regime. You can get molecules up to 70 kilodaltons to go through. But in order for larger molecules to permeate the focused ultrasound opening, blood-brain barrier opening, you will need to go past the inertial cavitation threshold and induce larger openings. So this tells us that the opening size can be dictated by the cavitation regime. So, and you also increase the area of fluorescence for smaller molecules, actually for all molecules, as you go in inertial cavitation. So if you want a larger area to where the drug permeates, you have to increase the pressure. Of course, the other thing that I want to mention here is that instead of doing one shot, as I mentioned earlier, so one application of the ultrasound, you could actually do multiple sonications at different regions, but you will still have to have them at larger pressures. Another thing that we have looked at was actually how to, again, make it as safe as possible. So how short of a pulse can you actually have to induce, to perform opening of the barrier. And we actually used about 3 cycles, and that was sufficient. I believe this was with Definity. And this is another fluorescence image with a 3 kilodalton dextran. Well, this is the hippocampus here. This is the contralateral side, and you can see the entire hippocampus lighting up with also some part of the thalamus. What we also saw with shorter pulses is that we had much more of a diffuse area. You no longer, except for the thalamus here, which is much more vascular, you don't have these punctate regions, but you have a nice homogeneous enhancement of the hippocampus compared to the contralateral side. And then when we took this to a confocal microscope that affords us much higher magnification or resolution, we started looking at these regions, and we wanted to see, obviously, whether those were capillaries or neurons. And it turned out at the scale that we were looking at that those were actually neurons. And we were actually seeing the uptake of dextran, in this case by neurons, with the dendrites coming out and the actual soma here. So that gave us more of the encouragement to start actually, we were reaching neurons with dextrans that do nothing to the neurons except, of course, supply more glucose. But we wanted to see whether we can actually deliver therapeutic drugs. And we started on this journey that we're still on, which is basically looking at neurotrophic factors, growth factors. One of the most promising ones is brain-derived neurotrophic factor, BDNF. We labeled this with fluorescence, and we were able to perform the similar task of looking at where the BDNF now is compared to the dextran. And we found it to be much more in the neurons. So the hippocampus, again, here is a cross-section. And these are what are called the pyramidal neurons in the region of the hippocampus. And it was very nicely highlighted. You also had some of the intrinsic the BDNF intrinsically getting fluorescent. The control hippocampus without ultrasound was actually also having some highlights. So you can see the neurons there, but much higher dose here. And then we started raising the bar. We're saying this is the extracellular space that we're looking at in the neurons, or we're actually inside the neuron. And then we were looking at downstream signaling, so we had to actually find out which receptor in the neuron will uptake the BDNF and which pathway was actually triggered in the neuron. So, what I'm showing you here is actually immunostaining. So here we have stained with the antibody the MAPK, which is a MAP kinase inside the hippocampus. And what you see in brown is basically where that MAPK was actually was actually highlighted compared to the contralateral side. And again, the pyramidal neurons here are actually where things were uptaken the most. And if you follow that pathway, it goes all the way to the CREB receptor. And I have another visual of that, illustration of that, when we look at the other growth factor, Nutrien. But we could actually see in blue is actually where the ultrasound and BDNF was applied. The control was the actual, the control was actually without any FUS or BDNF. And we could see that the TrkB receptor, we could actually we're triggering the TrkB receptor on the membrane of a neuronal cells. We go through the MAPK pathway, the AKT pathway, the other pathway for downstream signaling was not actually found as significant. And then finally, all the neuron nucleus and the CREB receptor. So we were entering the intracellular space of neurons and going all the way to the nucleus, which was great news for that, for this. So then we, after BDNF, we're looking at a similar growth factor that has also been used for treatment of Parkinson's. It was called the Nutrien, and it was actually in clinical trials with gene delivery. So we started looking at that and seeing how relevant this is in the caudate putamen, which sits right here. And this is the low magnification of almost the entire ventral brain of the mouse, sonicated on the left and contralateral on the right. And then when we look at these small regions at higher magnification, again, brown staining shows stains for the Nutrien itself. A much, very, very nice qualitative comparison between the contralateral side with Nutrien without focused ultrasound and the targeted with focused ultrasound in both of these mouse slices of the brain. And then, again, similar to what we did with BDNF, we're looking at the intracellular space, and we also were triggering pathways through the cytoplasm. That's called the ERK1/2 pathway, and also triggering the CREB. So you can see here an illustration of the cytoplasm here with the staining of the bladder and very opened region compared to the contralateral. And then the CREB also showing a much larger uptake of the Nutrien and triggering of this all the way to the nucleus compared to the contralateral side. And when we magnify this even more for the ERK1/2, we could actually see some of the nerve fibers that actually uptake the actual Nutrien. So this was actually some of the work that we're doing now to further localize how the distribution of the Nutrien and the downstream signaling in the brain. So we quantified that to see how we can actually get to see how much larger of the compound we can get to the brain, and it was on the order for the Nutrien on the order of 200% higher from the control side in both the substantia nigra and the caudate putamen. And then this is what I'm showing you here inside the neuronal cell from red receptor to ERK1/2 to CREB, also upwards to 100% increase in both regions that are affected in Parkinson's disease. And before I actually show you some of the therapeutic results, the last molecule that we were looking at was actually the adeno-associated viral vector, AAV1. We also worked with AAV2. And that's actually the largest molecule we worked with. That's now 10,000 times larger than the gadolinium. And this is now coronal slices, which are basically much more nicely aligned with the focused ultrasound beam, which is the axial dimension is actually within the plane. And in red, I'm showing you the sonicated side over the blue region, unsonicated. And now, instead of just showing you the molecule that has gone through, these are just the gene expression now, in this case GFP, the green fluorescent protein, that has only expressed in the sonicated region of bladder and very open region compared to the contralateral. And when we look at this other fluorescence, obviously this is the green fluorescent protein actually does fluoresce in the green spectrum. You can actually localize it and see which cells are actually uptaking the GFP. And in this case, the majority was neurons. Some of it was going to the astrocytes, but most of it, like 95%, was actually going to neurons. And again, completely absent on the contralateral side. and a higher magnification of that, it makes for nice images. You can see the entire neuron here uptaking the GFP, and also this is the merged image of the neurons in red and astrocytes in blue, and most of the green regions that are expressing GFP co-localized with neurons. And something I forgot to say is that this AAV in the genome had actually a promoter that's called synapsin that targets the neurons themselves. So we had that advantage. So it was actually targeting the cells that we wanted without affecting, inducing any toxicity to the surrounding cells. So there's ways to engineer the viral vector for that. So I should have shown this slide earlier, but this is basically what the neuronal cell membrane looks like. And then you have all these different pathways all the way down here to the cell. And we were triggering earlier this neurotrophic pathway on the RET receptor and all the way from the ERK1/2 into the CREB. So this is the part of the receptor that we were actually looking at. And for the AAV, it's a very similar way. The AAV is expressing now the GDNF, which is another neurotrophic factor called the glial-derived neurotrophic factor, and also expressing GFP that I showed you earlier. And in this study, we started actually looking at therapeutics. So we knew that we can get the dextran through. We knew that we can get the BDNF and the nutrient. Now it was high time to show it to see what it can be done in a mouse model of disease. In our case, we worked with Serge Przeworski at Columbia, who is one of the world authorities in what's called the MPTP model for Parkinson's disease, which is the most accepted model that induces some of the motor responses that are seen in Parkinson's and human Parkinson's. So the way it works is it's actually a toxin that depletes the neurons very, very fast within a couple of days. We actually used subacute regime on the order of 5 days, so it wasn't the most acute dose, small dose, with IP injection. And the timeline is shown down here. You have the microbubbles and the viral vectors injected first. Then we apply the sonication, and then we open the barrier. The AAV goes through, and then we make sure that we get the MRIs I showed you earlier to make sure that we open the regions that are relevant for this model. Then we wait 28 days because that's how long it takes for the gene to express the neurotrophic factor, the GDNF, and then we apply the actual toxin over the 5 days, the subacute dose. And then final sacrifice after about a couple of months, and then we look at things under immunohistochemistry. So obviously this is not the best human model because obviously the Parkinson's will come before the drugs, but we wanted to see whether we can get anything going here, because if we couldn't, then we will have to go back to the drawing board. So this is what all the different groups were: the control, focused ultrasound only, and we were only focusing again the ultrasound and opening the barrier on the left side, AAV only, and then finally the focused ultrasound with AAV. And in none of the other three groups were actually showing any significance between the sonicated region and the contralateral region, or the AAV itself was not doing anything because it was not crossing the barrier. Only on the last group, we were actually seeing some of the neurons that are surviving, and compared to the contralateral side, and everything that you see in brown here is actually TH staining, which is used to show neuronal viability. So anything you see in brown here are neurons. Substantia nigra, actually these two mustaches here, it's not actually the way I call it, it's actually how Serge calls it, which is the MPTP expert. And we saw it in multiple slices across different brains, and I'm showing you here one of the examples in higher magnification. The red region is actually the substantia nigra that were sonicated and with AAV, and the contralateral side with AAV only. And you can see the neurons here in the region of substantia nigra with the dendrites being still intact even after the toxin was delivered, compared to the contralateral side with AAV only, where some of the somas were actually depleted here, and the dendrites are actually not visible. And when we quantified that, we actually had to count all these neurons in the substantia nigra and in the striatum. We found that AAV only was not cutting it, mainly because of the barrier not being opened. Once we opened the barrier, then was several fold change in the striatum in both the viral expression and the substantia nigra as well. And finally, as I said, also the ipsi to contra ratio. So ipsilateral region is where we open the barrier versus the contralateral. So looking at the ratio between the neuronal population was only significant in the last group. And the same thing with the number of neurons was only significant compared to the control in the focused ultrasound AAV group. So once we got down and it looked promising, we actually started getting our hopes up, and we did something more modeling the disease more properly, which is we started with the toxin first. And in this case, we were already looking at nutrient. So instead of doing AAV that we're actually doing now, AAV after the toxin, I'm going to show you the results with the protein now instead of the AAV. So we started with the MPTP toxin first over the first 5 days. Then the mice were survived for 30 days. And then finally, we opened the barrier after a month. And then we delivered the protein after opening the barrier. And then we looked at exactly the same way the actual survival of neurons in immuno. And this is called the neurodegeneration study. So I'm showing you a couple of examples of mice, very similar of stain in brown are actually highlighting neurons that have survived the toxin versus the depletion, which is basically the absence of brown. So in the bladder and very open region versus the contralateral side, we had some very, very typical, very, very blatant examples, such as this one, which neurons cannot even be shown here. Compared to the very, very open side. And then some more subtle cases where you had more of the density on the bladder very open side, but the neurons were still surviving also on the contralateral. And then when we put them all together, so control, sham, focused ultrasound only, and focused ultrasound with nutrient. Now, unfortunately, I have flipped that, but we can only see survival of neurons on the focused ultrasound region compared to all the other contralateral sides. When we quantified that, very similar to the AAV, we could see also the group that underwent bladder opening with nutrient, and of course MPTP was the only one that had a significant increase in the ratio of survival neurons compared to the MPTP only. And if we look at just how each mouse did, in the group C, where we had MPTP with focused ultrasound only, no nutrient, this was not, the focused ultrasound was not, but the bladder opening itself was actually not cutting it. We needed the nutrient itself to go in, and in almost every single one of these mice, we saw increase in the neuronal population when the nutrient was actually going through. A couple of things I want to talk about before I show you our results in monkeys and finally the neurostimulation is other routes that we're actually looking at other than ingenious application of drugs. So focused ultrasound can be actually applied pretty nicely and repeatedly. The drugs themselves are, on one hand, can actually expose the entire circulation. We're trying to treat the brain, but obviously IV goes through all the organs, and finally the drugs can get cleared. There are some concerns with toxicity, especially with the adenoviral vectors, and also the cost can be significant when we inject large IV doses that only some of the drugs actually make it to the brain. So we want to look at alternative routes. One of them is intranasal. That actually has in the Alzheimer's disease has been embraced quite a bit. There's also what's called the smell test that people can do for diagnosis of Alzheimer's. Not as reliable as we wanted, but also there's now insulin delivery, intranasal delivery that actually has been in clinical trials for Alzheimer's disease treatment. So in our case, we did the same thing with the focused ultrasound. We opened the barrier. The only difference was that instead of injecting IV, we did intranasal. And long story short, we can actually deliver similar amounts in intranasal delivery as IV. So what we're doing to the mouse in this case, we were injecting still microbubbles intravenously, but we're just doing nasal drops on the mouse to get the dextran in this case through. So very similar intensity. Now for the fluorescence region, we had larger diffusion areas in IV, significantly larger compared to IN, but we can actually get significant areas, regions of enhancement regardless with intranasal. Another thing that we're looking at is with nanodroplets. So these are specific molecules that you can inject instead of microbubbles. So in what I've been showing you so far actually are lipid-shelled microbubbles that have a gas core. And Paul Dayton's lab at the University of North Carolina takes them, condenses them, and then drops the temperature. That increases the pressure and makes it nanodroplets. So the advantage here is that they are much smaller, and they can get to a lot more vessels at the larger doses. And then as soon as the ultrasound, as soon as they are actually within the ultrasound beam, they turn into microbubbles. So you actually make microbubbles where you need them. And this is a visual of this movie that was running down here. Wherever you can actually start seeing these bubbles is actually where nanodroplets are converted to bubbles. And they're much smaller, as I'm showing you here, on the order of 200 nanometers. So we started using them to see how they can actually help us compare to microbubbles. And what we're showing you here, this is work by Cherry Chen in my lab, is that we can get with nanodroplets a much more localized effect and much more homogeneous compared to microbubbles. And we can also have it much more safely. So here at 0.6 megapascals, we can still do things very safely compared to what I showed you earlier with microbubbles having some small regular cell extravasations. So we are currently also looking at that as an alternative, especially since these nanodroplets have higher persistence in circulation compared to microbubbles. Okay, so these are all on small animals. So I want to spend this last part of the bladder and berry opening talking about what we've been doing in the monkeys. So in short, the same thing translates, the same technology translates in monkeys very nicely. It wasn't easy to figure that out because the brain is not only larger, but it's also much more complex, similar to the primate brain. So in this case, very similar system. We actually dropped the frequency to 500 kilohertz from 1.5 megahertz to bypass the thicker skull. And this is a visual of what a system looks like on wheels. And this is a transducer and a stereotactic system. The head of the monkeys down here, I'm going to show you another image later, but we can position at different angles. And one of the things that we had to develop was real-time monitoring. So obviously mice, we love our mice, but they're much cheaper than our monkeys. And we had to develop something that we can, it can show us that it's safe during the application. I apologize for some of the graphics here, but we can actually see the stable cavitation in blue. You can also see a rise of the bubbles going in blue, and then in red, you can actually see some of the ultraharmonics. And finally, the inertial cavitation is in the black line here that shows you that things that we actually open the berry without inertial cavitation. So this is actually our measure of making sure that the actual application is safe. And this is another still frame of another experiment. So this is the rise time of the bubbles going into the brain. So we inject here, and you can see the increase in volume leads to higher cavitation dose in the putamen and the caudate. The two flat lines here are showing that it's safe. And then we associated with the three-dimensional MRI showing us in the putamen localized gadolinium enhancement in two separate regions, and the caudate also localized enhancement, very homogeneous enhancement, gadolinium penetrating in the brain through the open barrier. This is another image of the actual monkey anesthetized, and this is where the caudate putamen lie. Another picture of our transducer system with the anesthesia here. We typically use 10 millisecond pulse length, 2 Hertz VRF, and 2 minutes of sonication with our homemade bubbles at 4 to 5 microns. A lot of safety other than just the cavitation monitoring after the fact. We take the animal to the MRI. We perform all kinds of different sequences, T2, statistically weighted imaging, fold gradients, before gadolinium gets injected, and again the same thing after gadolinium injection, so to make sure that we don't have any edema or hemorrhage. The opening detection was actually much more difficult compared to the mice. The brain, you can already see, has a lot of more gray matter, white matter, and I'll show you how this is affecting our opening. And it was more difficult to visualize just on regular T1 weighted image, the opening. So we had to look at what we call the T1 maps that helps us isolate the regions of opening. You can see we did actually 2 different openings here in this specific animal in the coronal slides. And then again, similar to what we're doing in the mice, we also could see the permeability, but in this case, Mania Samniotaki in my lab devised a sequence in MRI where we can actually see the concentration of the gadolinium, and that was actually huge for us because obviously one of the questions we get is how much of that gadolinium that you inject IV makes it to the brain. Now we can tell them we can tell them how many millimolars of gadolinium are in the brain, and also the whole distribution. So that gave us this is a map that we can actually use with the animal to develop to see how the percentage of dose in the monkey. Some more images on one of the animals that we were using. So you can see after gadolinium, very difficult to make out the 2 openings that you see here. With our methodologies, we can see both the openings, the concentration, and finally the permeability that has increased in the 2 sonicated region, the putamen and the caudate. And you can see that the pressures are also very similar to what we had in the mice. Another example of another monkey where we had blood-brain opening in the caudate at slightly higher temperatures, and seeing concentration, lower concentration in this case, and also 2 different regions. And we started seeing this disconnected regions, and we weren't sure exactly what was happening. Why don't we get this nice homogeneous openings that we were getting also in the mouse? And we started looking, as I said earlier, to the gray matter, and some of you who know the MRIs of the brain, this is the visibility weighted image, and we can see some of the white matter tracks here. I'll show some of the examples later. The pressure does affect things quite a bit, so you can go from a smaller region to a larger region just by doubling the pressure. And the same thing holds for the concentration, that the larger pressures lead to higher concentration of the gadolinium going to the brain. So the pressure itself can drive both the volume and the concentration. So for the gray and white matter, as I said, we wanted to separate how the volume, what happens actually, why the volume is affected by the white matter, and then how it's affected. So it's known that the gray matter is actually more vascular than the white matter, and you wouldn't expect to have the same blood-brain barrier effect on the white matter as in the gray matter. So we had in 2 different monkeys, I'm showing you results with the volume of opening, with different pressures, but also what we found as a gadolinium concentration in micrograms. And we were able to see that in the white matter, you have less of the increase that you see in the gray matter as you increase the pressure in both monkeys. And then with the gadolinium concentration, most of it, the rise with pressure was actually in the gray matter. Some of it was also in the white matter with the concentration itself. For the one monkey, the other monkey, we actually saw almost no change in the white matter. So the gray matter is definitely the most reliable region of taking the gadolinium in this case. It does also work in the white matter, but not as predictably. So, and regarding the actual dose that we have of the gadolinium itself and the delivery efficiency with pressure, so in these two monkeys, we found it overall to increase with pressure, as I said, but you still have a pretty low efficiency, so it goes back to what I said before with IV, you get 0.07% of what you actually inject into the brain itself. The good news is that this is actually shown to be on the dose itself is actually therapeutically relevant, because that's how much actually they do inject through in convection enhanced delivery or even intracranial injections. So we are getting volumes that are actually relevant. Safety-wise, as I said, we have done a lot of safety work, a lot of MRI images. Overall, no edema or hemorrhage was observed at specific pressures in several of our 6 monkeys or 7 monkeys we have now. We also monitor weight, heart rate, breathing rate, and blood pressure. So those have not been shown. Actually, anesthesia is affecting those much more than the ultrasound itself. And some of the work that we published in the past is that it does, at higher pressures, it does take also a couple of days for the opening to recover in the primate's brain. So overall, very similar findings in non-human primates as we've seen in mice. And then we started going into awake animals. This is some of the work that Matt Downs in my lab presented at ISTU a couple of weeks ago. So the way that we envision this to happen in the humans will be under awake the wake regime. So it's important also for the surgeon or whoever practitioner is actually applying this to get some feedback from the patient. And the good news is that the actual openings are actually easier to actually have in the awake brain compared to the sedate brain. There's been one of the hypotheses or one of the interpretations of this is that the vessels tend to dilate as a result of anesthesia. So the bubbles all of a sudden become smaller relative to the blood vessels. So it's much more difficult to open the barrier, or more difficult to open the barrier in the sedate. We don't know exactly why, but this is one of the potential reasons. Another reason could be that the pressure is higher in the awake. Obviously, the heart rate is higher, so that could also affect. We don't know exactly, but this has been, pretty much something that we have observed in the awake versus the sedate. And also the stable cavitation dose is very similar. Initial cavitation dose between awake and sedate, very similar to what we find between awake and anesthetized. We also do physiological monitoring. We have some electromyograms in the temporal muscle. So this is the muscle that sits above the skull, and we're trying to see how we're affecting that. This also affects the stimulation project that I'm going to talk about briefly after this. And we see no abnormal EMG signals or no significant variation in the heart rate whatsoever during awake sonication. And something that we see overall, so this is actually together with Vincent Ferreira in neuroscience at Columbia, we actually looking at these awake monkeys also doing behavioral tests. So our monkeys are actually very busy during sonication. They actually have a touch panel that I don't have time to actually show you, but they are actually hitting targets on the touch panel. We try to see whether any of the cognition is affected during sonication. So we have what's called the pre-group, during group, and post-group. So these are 2 monkeys with NHP-A and NHP-Z, where they actually have to hit a cue and then hit a target. And we've seen a slight increase in one of the monkeys, the duration. So this is reaction time, so how fast they can actually hit the target. So there's an increase in reaction time in during group in the one case, one monkey. But overall, we see in another monkey a decline between pre and post. So the reaction times after ultrasound are actually getting, faster. So very preliminary results, so we don't know exactly what to do with them, but we have an overall decrease in reaction time as a result of the opening. And then when we look at the touch accuracy, so how many times they actually are hitting the right target, that also is slightly improving after post. But this is very preliminary results. I just wanted to share with you right now because we're going to look into that. So the good news is that we're not affecting the behavior of the animal, and now we're actually seeing some of the improvements, very preliminary in touch accuracy and in reaction time. And finally, with drugs, that has been a little bit more difficult to see. There's many drugs that can actually make the animals more drowsy or more slow. One of them is haloperidol. That's a dopamine antagonist, so that means that it makes motor control much slower. And we are trying to iron out through the behavior results. This is a reward bias. So this is basically the animal that gets rewarded every time it reaches the right target, but it also gets rewarded higher reward. This is a water reward. So instead of getting 1 drop of water, it gets 5 drops of water when it reaches a more difficult target. So we are affecting that. So the drug does go through at larger doses compared to the other groups, and compared to no BBB opening and BBB opening with saline, we get the actual reaction time to drop to be on the same non-significant with low reward and high reward. Some preliminary examples of drug delivery to be working in non-human primates through the blood-brain barrier. And the final thing is that on the human skull itself, we're doing cavitation monitoring. This is some of the work that we published last year by Xing Wu in my lab, where we have the nose skull. So this is basically getting stable cavitation detected together with ultraharmonics and inertial cavitation. We can get them above the threshold of detection. And also in the monkey skull. And the ex vivo skull now in humans, much more difficult to get a nice signal outside of the skull. And actually we see drop at higher pressures, but we can definitely detect it above the actual threshold that you see here as a dotted line. Okay, so the last part, and hopefully I have like no time, but I'm just going to wrap it up. So we have gotten really interested in neurostimulation lately in my lab over the past year. We had a student visiting from Brazil, and we're trying to find an exciting project for him. And so since we're already working on the brain, we wanted to see what we can do in the stimulation. And then as we were stumbling upon different things, we found out that this may be actually something also very clinically viable as a technique. And of course, we're not the only ones, but I just want to show you what we have been doing in my lab. So obviously, deep brain stimulation has been around, especially for Parkinson's, for a long, long time. It is reliable, but it's invasive and involves surgery. And there's also a lot of indication of neuromodulation that are rapidly on the rise. I'll hit that in the next slide. So we wanted to see whether focused ultrasound, which can be a low-cost, non-invasive, and selective alternative to DBS, could be used in the treatment, in this case, of neuropsychiatric disorders. So these disorders are actually affecting millions of patients. And I was actually shocked to see this graph, which is basically the current DBS patients are 150,000, but there's many advanced cases of Parkinson's where they actually are not necessarily getting DBS. There's about 5 million. And then you have what's FDA approved. Obviously, you know about the essential tremors and also dystonia and OCD, together with Parkinson's, affects 20 million patients and all the other disorders. So there's about 85 million patients that are typically right now, when the drugs fail, it's very difficult to necessarily go directly to a surgical procedure. So it could potentially, with focused ultrasound being there, could get less hesitation from patients. and referring MDs to get this as an alternative to DBS or maybe as a precursor to DBS, and to see whether stimulation will work and could have some FDA approval down the line, because I know this is actually an interest of the foundation. So I'm showing you here the table of what I said earlier: essential tremors, Parkinson's, dystonia, OCD, all FDA approved, but very few with DBS, and affecting about up to only these disorders alone are 20 million people. And then right now, DBS is actually proposed in trials for treatment of major depression, Alzheimer's, epilepsy, and post-traumatic syndrome disorder, and that accounts to about 100 million patients. So this is actually what's on the pipeline down here in black, and this is what's actually approved. So what can we do? So we'll go back to the mice. So this is our ugly setup, I'll give you that. But we have the transducer up here. We had to change it slightly from the bladder berry opening. We usually tape our mice on the plate, but in this case, we're trying to see we're trying to detect motor control. And long story short, the anesthesia was actually a big part of this. So it's actually ultrasound people using the brain without knowing much. So we used the right anesthesia. We had deep anesthesia. And then we went on the contralateral side and applied sonication at about 4 megapascals. And you're going to see on the left we're stimulating, and you're going to see the hind paw moving selectively here. I'm just looping the same thing. It's not continuous. And you can see almost the paw tapping. So we get selective regions of the brain that we can stimulate. And of course, we did it a few times, and I don't know if all these moves are going to run, but we went on a grid around the entire brain, and we stimulated in red. Ipsilateral side shows also motion together with contralateral, but we could selectively get one paw or the other to move, and sometimes you could get also the entire hind region. But what we wanted to do is actually get selective regions of the motor control as opposed to the entire mouse body moving, and we could get that. And the final one, I know it's not Halloween, but this is probably how it's going to look like, but we actually can get also in the locus coeruleus in the brain, similar to selectively, as I showed you before for motor control. We can also induce pupil dilation and rotation of the entire eye orbit as a result of the ultrasound. And you can see when we switch off the ultrasound, it comes back. This is the entire movie actually playing here. Okay, so in summary, the bladder and berry opening, we've seen that the mechanism will be stable bubble oscillation that causes bladder and berry opening for molecules that trigger downstream signaling. Safety-wise, we found it to be safe in mice at or below 0.45 megapascals, and the same actually also applies in monkeys. The efficacy, the permeability is increasing with pressure and the microbubble diameter, and that leads to drug delivery of neurotrophic molecules and biovectors that trigger the pathways that I mentioned earlier, that now recently we found that also have therapeutic effects for neuroprotection and neuroregeneration in a Parkinsonian model in the mice. And from the mice to monkeys, we found very similar bladder and berry opening and safety, and very initial findings in drug delivery. And for the neurostimulation, we have both IPSI and contralateral limb and eye movement caused by the ultrasound alone. So I want to thank my entire group. We're very lucky to have great students and postdocs in my lab. So Maya Samyotaki did the work of neuroprotection. Mylena does a lot of work on the monkeys and the angle dependence. Matt Downs is actually looking at the awake patients, and Shuta Wang is looking at the viral vectors together with Hong Chen, who does the BDNF for Alzheimer's. Thank you for your attention.
Does anyone here ask questions? Or? Can you switch with me? Oh. The first question, you mentioned that one of the reasons of looking at intranasal was because of losing drug in other ways. So I'm wondering, with different methods of injection of the drug that you've tried, roughly how much drug are you losing in each? Like, do you have percentage-wise that you're...
We haven't looked at that. We haven't looked at that because it will get depressing very fast. But in the case of the gadolinium, it's basically why we did the study. And of course, it's in the large animals because that's basically where we start really worrying. It's a bigger brain. It needs a larger dose because the dose is always with the weight of the animal. So this is where we started actually looking at how much of the efficiency we're getting through the injections. And as I showed you, it was, I don't remember, 0.0005%. So we expect a similar thing to happen in the mice. Now, I don't know how much of that is molecule dependent, but we can look into that. And we actually are starting to do ELISA now to measure the amounts and also HPLC. But it's not as straightforward as it sounds, but we're getting there. But we expect similar efficiencies because it's IV. So.
Can you tell us more about the sonications, how long they were? Do you have to just do one sonication to open up the BBB, or did you have to do several in an area? How does that work?
So we have done a very small number of sonications. So we go with the bare minimum, which basically makes it harder to see any therapeutic effect. But it basically can only get better because obviously the more openings you have, the more regions the actual drug is going to go through and treat the brain. So in the case, for example, of the neuroprotection and neurodegeneration studies, we were actually in the AAV trial, we're only doing one sonication, 1 minute. And in the case of the neurodegeneration, with Nutrien, we had 2 sonications, one in the substantia nigra and one in the putamen, so 2 minutes of opening.
How do you, so did you do few for like just pure to be conservative as possible from a safety perspective? I guess the question is the next step to like do a similar study and actually have the variable being how many sonications you do? Like, how does that progress?
Yeah, so obviously we were dealing with mice in that case, and what I tried to show, but I went fast, was that with single application, actually, we figured out the sequence that we have to apply so that with one application of ultrasound, you can actually infuse the entire hippocampus on the entire putamen or the entire substantia nigra. So we didn't need, so these are tiny little regions, right? And our beam is pretty large compared to the mouse. So in the case of the mouse, we didn't need to do multiple sonications. In the case of the monkeys, we may have to, and we'll be discussing this, especially for the drug study, the haloperidol study, because we actually are having only a single sonication in each region. So we probably were following the paradigm of the mice too closely, where we basically were lucky there because of the small structures. So you could actually do 1 minute and then infuse the entire region. Now we probably have to increase the number of sonications to make sure that we have a critical dose go into the brain that can treat it. So, but we're not there yet. So the problem with again, as I mentioned earlier, the drugs are very expensive. You go IV, and we don't have the budget to actually do necessarily these expensive drug studies in monkeys. So we don't necessarily have, we have the gadolinium going in, but the gadolinium does infuse very, very similar way to the mouse. It does infuse a large region of the monkey's brain, but it doesn't treat it, right? It's just highlighting it. Yeah. And it's much more smaller molecule. So it moves around more. Yeah, it's actually exactly designed to move and be cleared. Yeah. So So everything we do obviously has to be in tandem with the drug or the molecule that we inject. So we can. The good news is that we can tailor this to the drug. So if you say that I have a drug that needs, you need to open the whole caudate and the putamen and the substantia nigra, so the whole striatum, we can do that. It's just that we don't have the drug. So we do the studies when we have the drug. So in this case, our drug is still like a gadolinium in monkeys. So once we find the drug, the good news is that we can open in different regions. It's going to take longer, but it's definitely per region. It doesn't take as long. So.
Have you also done, or you have also done work in Alzheimer's disease models, correct?
Yes, we have.
What have you found there?
So in mice, in Alzheimer's mice, we actually are doing a study right now that involves neurotrophic factors, and in the Alzheimer's models, but we don't have the results yet. But it's very similar. We try to show downstream signaling in Alzheimer's mice and also neuroprotection and neurodegeneration in mice. It has been a little bit more of a challenge because those are transgenic mice, and we needed to have enough of a population so that we can have all these 4 different groups of control, focus ultrasound only. So it has been a little bit slow, but we hope to show very similar effects in Alzheimer's as well. With amyloid, when we did this study a while back, we didn't find any clearance with our studies. And I think the reason why we didn't find it is because we didn't treat the entire brain. So the paper that showed from Australia that you can clear amyloid with just ultrasound alone, and of course the bubbles have to be there. They treated the entire brain, so I think that makes a huge difference as opposed to just treating just the hippocampus itself. So, but ourselves, we actually had the same kind of, when we did this almost 8 years ago, we had the same hypothesis. Maybe the plaques are just through the radiation force alone, we're just being dislodged, and we're like, oh, what are we going to see under histology? The plaques are going to be gone and maybe aggregate in the corner. But we didn't see that. They were just intact for us. The other thing is that we didn't survive them long enough. We sacrificed within hours.
So when you saw that paper out of Australia that came out last month, what was your response, and how do you feel like your work related to what that work shows?
So I was somewhat familiar with that work because they came to us a few years back, and they were trying to set up something similar to what we're doing, and we had some conversations back and forth. I didn't know they had advanced that far, and I thought it was fantastic that they actually could do this without a drug. So I was very pleasantly surprised, and the most significant part, I think, was that they figured out why. Because it's one thing, an observation of, amyloid is gone, and another thing to actually sit there and find out that the microglia were responding to albumin going, through the blood-brain barrier, and potentially activating those was actually a big deal for clearing amyloid. So I thought that was very nice to bring neuroscientists into the blood-brain barrier opening with ultrasound world, because we need them as much as probably as they need us.
So a more mechanistic question. Earlier in your talk, you talked about bubble sorting.
Mm-hmm.
So a group of bubbles that were 1 to 2 microns versus one that was 4 to 5. And you saw a larger volume of blood-brain barrier with the larger microbubbles with the same ultrasound parameters. So do you know why? And I guess my suggestion is maybe it has to do with the bubble resonant frequency being more in line with your ultrasound resonance.
True. We don't know exactly why. But what we think is going on, we know that a frequency of 1.5 megahertz matches more with the 2 microns, according to the models. So that's not explaining exactly the entire thing. But what I said earlier was the capillary diameter, which is in the order of 4 to 8 microns. The bubbles are now starting to match the capillary diameter, and it's much easier for them to reach and touch basically the surrounding endothelial cells and engage them with the same type of oscillation. So we think the efficiency is actually increasing. That's basically the idea. So but we don't know whether that's actually what is happening. But it does also it actually does saturate with 6 to 8 microns. So you don't get a linear increase. So at some point, 4 to 5 or 6 to 8, you stop there. And 6 to 8, we've seen actually that gauge is probably too much of the vessel, so you can get actually the damage much faster. So 4 to 5 is actually our sweet spot, and the same thing actually goes with monkeys, and we only use 4 to 5 microns now in monkeys. We use nothing else. So.
Okay, well, that's going to conclude our webinar for today. So I thank you all for joining us, and stay tuned to our newsletter and our website for invitations to future webinars.